Chief, I'd like to introduce Professor Michael Reade. We all know Michael. He's a clinical scientist with the Defence Forces and an intensivist at the Royal Brisbane. Has an extensive history or extensive experience in military trauma medicine. Has disappointed me hugely by turning up in a very smart civilian suit, but good to see you anyway. And we're going to talk to us about fibrinogen concentration, viscoelastic testing, targeting the essence of trauma coagulopathy, or an unholy alliance. Thanks, Mike.
Thanks very much, Mary. Thanks also to the organisers for the invitation to speak. Well, that's quite a mouthful of a title, but really the essence of what I'm trying to get across is that in recent years there's been, as you've heard, an increase in interest in availability of viscoelastic testing, TEG and ROTEM. And it's come at the same time as clinicians have become increasingly interested in replacing fibrinogen, in part because of results of those tests which tend to show a deficiency in fibrinogen. And my question is, when that happens, when that confluence of increased test availability and increased availability of a treatment occurs, whether we're actually doing something that benefits patients or whether we're just treating a test result and not having benefit to the patient as a result. So I'm going to lead you on a journey of discovery through some evidence, and I'm going to let you make your own mind up at the end. My conclusion, though, at the end of this talk, I hope, is going to have you come to the belief that maybe this is the sort of thing that we could subject to a randomised controlled trial, and that in Australia will be the Feisty trial. And if that is put to you in your centre, perhaps you too would have equipoise for that trial and you might choose to participate. I don't have any financial conflicts of interest, but and also I'd hasten to add I'm not one of the Feisty investigators, although I have had extensive discussions with them, and I'm very grateful for their input to this presentation. The bottom line for the clinicians in the audience, though, if you, I guess, want to fall asleep in the middle of this, is that I do believe fibrinogen replacement is important, and I do believe that guiding that replacement with a TEG or a ROTEM is probably better than guesswork. But there's a little bit more complexity that we'll go into. All right, so fibrinogen is required to make a clot strong, and you can tell that just by simple inspection of these electron micrographs, where you can see that normal clot has a lot of those fibrin strands, and when you dilute out the fibrinogen, the clot looks less strong, and then when you add back in the fibrinogen, the clot looks stronger again, and I guess you can intuitively see that that's a good thing. If you dilute blood, then the first factor to fall to a critical level is fibrinogen. So that's why we're talking about this as potentially the most important factor in coagulopathy, in trauma in particular. And it's not difficult to find studies that associate low levels of fibrinogen in trauma with bad outcomes. So here's just one, but there are a number in the literature. This one found a critical value of fibrinogen of about 2.29 grams per litre associated with a higher risk of mortality. Okay? So that seems to be the problem, a low fibrinogen, and we have a solution. We can give fibrinogen concentrate. Oh, my watch is talking to me. So we should just do that, shouldn't we? Well, the National Blood Authority doesn't seem quite so convinced. It restricts the availability of fibrinogen concentrate to people with congenital fibrinogen deficiency and to people with haemophilia. So you're not allowed, it doesn't at least fund, fibrinogen concentrate for people with acquired fibrinogen deficiency in trauma or massive transfusion. You can give it as an off-label indication, but it won't be funded by the National Blood Authority. In a sense, your hospital would be funding that itself as an off-label indication. So let's just explore why that is, because of course the NBA is bound to apply evidence-based medicine. Well, looking back to that study, for example, which associated low levels of fibrinogen with poor outcome in trauma. The problem with that type of study is that, of course, association doesn't equate to causation. If you have a higher level of injury severity, you would be more coagulopathic, you would have a lower fibrinogen level, and you'd be more likely to die. But that doesn't necessarily mean that your lower fibrinogen level made you more likely to die. And even if it did, even if those two things were causally related, it doesn't necessarily follow that replacing the fibrinogen back to a normal or even supranormal level would necessarily fix your mortality. Now, it might be true, but it doesn't logically follow. When we go looking for evidence of hypofibrinogenemia in trauma patients, we find some inconvenient truths. This was the large observational study that preceded the proper study that Zoe's just described, where they looked at massive trauma patients who came in who were and who were not coagulopathic, and they looked at a variety of clotting factors and, for that matter, activated protein C, which they found elevated, and therefore found some evidence of what we describe now as acute traumatic coagulopathy. But if you look in these columns that I've highlighted in green here, this isn't a misprint. The patients who were coagulopathic actually had a higher fibrinogen level than the ones who were not coagulopathic, which doesn't fit our theory at all. And yet you don't hear this presented very often. It doesn't fit our common conception of what's really going on in trauma coagulopathy. Here's something else that doesn't quite fit. The REPLACE study of cardiac surgery, where they hypothesised that using fibrinogen concentrate in cardiac surgical patients would reduce the amount of blood products that were used in those patients who tend to require quite a large amount of blood product replacement on cardiopulmonary bypass. In fact, the reverse was true. If you were randomised to the fibrinogen concentrate group, you needed more red cells transfused, you needed more FFP transfused, and you had a trend to need more platelet transfusions as well. That doesn't fit at all. Now, that might just be statistical kind of play of chance in about a 150 patient study, but it might be telling us something that we don't quite yet understand. Perhaps having got fibrinogen concentrate, you didn't get a whole lot of other stuff that the patients might have otherwise received in plasma, for example. Maybe there's something in plasma that's not in fibrinogen concentrate that stops you bleeding, maybe something that preserves the endothelial glycocalyx. And maybe that is quite important. Who knows? The trial doesn't tell us, but it at least raises the question. It at least makes us think that maybe just pulling the fibrinogen concentrate out of the bottle isn't the magic solution that everyone often thinks it is. You often hear that there's an economic argument too about fibrinogen concentrate, and here I'm going to dispel that argument. I've looked at the different costs of delivering fibrinogen, either as a concentrate or as in cryoprecipitate, or for that matter as FFP. And as you can see in red at the bottom, an equivalent dose of fibrinogen concentrate in Australia compared to cryoprecipitate is essentially the same. The trouble in Australia is that in public hospitals at least, we don't pay for the cryoprecipitate, whereas we do pay for the fibrinogen concentrate. So there's an economic argument, but it's a false one in a sense. The society pays the same, it's just our hospital pays a different amount because they're funded differently. FFP is cheaper, but of course FFP is not really comparing like with like because you need to give a larger volume of FFP to give the same dose of fibrinogen. Are they clinically equivalent? Well, there does seem to be a problem with giving fibrinogen either as FFP or cryoprecipitate in terms of time taken to deliver the intervention. This is an observational study done by the London Trauma Group that looked at essentially whether they were able to deliver fibrinogen as cryoprecipitate or FFP quickly in their trauma resuscitations. And as you can see, I've highlighted there in red, they were able to really only achieve a ratio of FFP to packed cells when they were aiming for 1:1 of only about 1:2 or 0.5. In their FFP to red cell ratio, and really they didn't get cryoprecipitate in at all because of difficulties in essentially thawing those products. This is Zoe's work from the Massive Transfusion Registry in Melbourne showing essentially the same thing, that fibrinogen administration, if you're going to use cryoprecipitate as your method, is relatively slow. It takes about a median of 1.5 hours for the laboratory to issue cryoprecipitate, suggesting that this drug might be better. You should be able to give it more quickly. It takes a little while to reconstitute, but you should be able to give it more quickly. It's got a number of other advantages as well. It's temperature stable. You can keep it on the shelf. It comes as a known dose where there's a variable amount of fibrinogen in cryoprecipitate, although that is improving as the blood service gets to know the fibrinogen content of its donors and tends to take cryoprecipitate from people with a known high concentration of fibrinogen. But of course, knowing the dose doesn't really count for a lot if you don't know the dose to give the patient, but still, it's a start. The possible problem, though, is that unlike FFP, it doesn't contain volume, so you're going to have to give that volume as something, presumably a crystalloid. So, should we not just do it? Should we not just give fibrinogen concentrate? Well, the European guidelines for bleeding and massive transfusion really sit on the fence. They say, well, you could do one or you could do the other. And if you're going to use a concentrate-based strategy, well, you could use fibrinogen concentrate or you could use cryoprecipitate. And essentially, they say in their 2016 iteration, you could do either. We looked at this in 2014. We looked at the evidence supporting fibrinogen concentrate in trauma, and we really didn't find any randomised controlled trials in trauma patients. We found some observational studies, but no trials. And the Cochrane collaboration also looked for trials, not just in trauma, but in elective surgery as well. And they found 6 essentially low-quality studies on which to base their conclusions, and they found essentially that more research was urgently needed, and that really, if you were going to choose one or the other, ideally those choices should be made in the context of a randomised controlled trial. And the European guidelines back in 2013 also said that we desperately need well-designed controlled trials in the area of fibrinogen replacement. Now, this is just a bit of an aside, but it's kind of an amusing anecdote that I think might amuse you as well. Commenting on that Cochrane review that said we need more evidence and there's not really much to guide our practice at the moment, a number of authors, including the authors of the European guidelines, said, well, look, we don't agree. We think there is enough evidence to guide practice now. That existing blood products don't have much evidence, so holding fibrinogen concentrate to the same level of same standard of evidence is inappropriate. And lots of people use fibrinogen concentrate, so it doesn't seem to do any harm. We should just do that. There's nothing suitable as alternatives. We can give it quicker at least. And you talk about cost. Well, cost is different in different places. And they did declare their conflicts of interest, and interestingly they had dual conflicts of interest, both with the viscoelastic testing and devices and with CSL, the manufacturers of fibrinogen concentrate. So the authors of the Cochrane guidelines wrote back and said, well, we note that you have these conflicts of interest, and we suggest that this is more like scientific marketing than scientific evidence. And then the authors of the other paper wrote back and said, well, yes, you would say that. You've previously published with Dr. Bolt, who we all know is the scientific devil. Some of you work in Thailand, which is clearly an inferior healthcare system by implication, if not by what we're actually going to say in our paper. And some of you probably don't even look after patients. You work in an ivory tower. So we're going to discredit your opinion piece. So there was this kind of tit for tat in the scientific literature, which wasn't really very edifying, but I think speaks to the vested interests that are at play in this area. So what are the real theoretical arguments? Why am I not just telling you to give fibrinogen concentrate? Well, there is a little bit of a risk of procoagulopathy. There's a very, very theoretical risk of a product that comes from multiple donors. There's probably a more substantial risk of the fact that fibrinogen concentrate lacks von Willebrand factor, which is present in cryoprecipitate, and maybe other important components that are present in FFP, and also the volume issue that there is in FFP. But then in red there, probably the most important thing, that potentially we're just treating the test results rather than having patient benefit. So let's just look at those in a little bit more detail. You can certainly give enough fibrinogen to increase the incidence of DVT. Here's an observational study that showed just that, the odds of DVT going up as fibrinogen concentration goes up. So you need to be careful with how much you give. I think this is what this says. But that's fair enough. We're careful with how much of all sorts of things we give. Does it matter that the fibrinogen concentrate in the vial comes from multiple donors? Well, it's virally inactivated. So for any known infectious pathogen, it doesn't matter. really only matters if there's an unknown infectious pathogen, a prion or something that we haven't yet identified. And this worries some people, but it's a very theoretical concern. A less theoretical concern is understanding that fibrinogen is actually a tiny fraction of everything else that's in FFP. And the idea that everything else that's in plasma is not really doing anything in trauma resuscitation seems to me, very, very intuitively, a little bit naive. And is there any evidence for that? Well, it's a little bit. This is another talk, really, but we're very concerned now about the integrity of the endothelial glycocalyx in critical illness and in trauma in particular. And here's a study, an in vitro study, admittedly, that shows resuscitation with a variety of different fluids in a trauma model, showing that, in this case, Hextend, lactated ringers, strip off the endothelial glycocalyx, whereas it's preserved by FFP. So what is it in FFP that's preserving the endothelial glycocalyx? Well, we don't know. Does fibrinogen concentrate have the same effect? Well, we don't know. So we should probably find that out before switching entirely from a plasma-based resuscitation strategy to one based on concentrates. We talk about validation of viscoelastic testing, and you'll read in many places that viscoelastic tests are validated, but we use that term without really understanding, I think, a lot of the time what it means. This is a terrific paper that explores that concept. Validation is generally meant to, in this context, imply that the test is repeatable, that it lines up with the results of other tests. But what we as clinicians want it to mean is that it tells us something that's useful for the treatment of the patient, and that's a long way from having been established for viscoelastic testing. Why is that? Well, people will say that the viscoelastic testing tells you everything about blood clotting. It doesn't just tell you what the INR and the APTT tell you, but it also tells you about all the other factors that happen in the clotting cascade in blood. Of course, that's only part of what happens in blood clotting. The other part is the interactions with the vascular endothelium, which of course is abnormal in trauma, and it doesn't tell you anything about that. So the idea that these are validated tests that tell you everything about the coagulopathy of trauma is, at least in theory, not likely to be correct. But this is going to get much more common. We're going to see many, many more, or much more commonly, the results of these tests in our clinical practice, because the next generation of these machines is just hitting the market in Australia and worldwide, whereas previously you had to use a pipette to load these machines, and many clinicians had long ago forgotten how to use a pipette in second-year biochemistry. Now all you have to do is load a cartridge into these machines, and it's essentially like a blood gas machine. So these will come to an ICU near you within the next year or two, I would predict, and they'll sit next to your blood gas machine. So we're going to be seeing these results, so we're going to have to know what to do with them. And that suggests that we're going to have to deal with this potentially unholy alliance between the people who are trying to tell us that we should use fibrinogen concentrate to treat the test result that says that you should give fibrinogen in some form or another. And Teddy Roosevelt's my favourite president, so when I googled unholy alliance, this quote of his came up. So unholy alliance, he identified as the alliance between industry and some elements of the US government, which he saw as his role to try and befoul. I say he's my favourite president. He was neither left nor right wing. He kind of broke strikes with the army, but at the same time he established the Forestry Service. He won the Medal of Honour in Cuba, and he kind of got things done. But in particular, he was against this kind of behind-the-scenes collusion that got in the way of the right thing. So anyway, by way of aside. So why might there be an unholy alliance? I'm not suggesting there's anything bad going on by intention between the manufacturers of any of these things, but might be the unfortunate coincidence of having a test result and a drug come at the same time. Well, TEG and Rotem do seem to reduce transfusion requirements in cardiac surgery of every product other than fibrinogen concentrate. Many studies I could show you. Could fibrinogen use in those studies be increasing because we're treating the test and not the patient? Well, possibly. Transfusion requirement is associated with adverse outcomes in other contexts, so you would think if transfusion requirement is bad for you and you're reducing transfusion requirement, the outcomes in those studies for the patients should be better, but they're not. So might it be that there's some sort of detrimental effect of using just fibrinogen concentrate that's being offset against the positive effect of using, of avoiding the transfusion of other products? Well, that's possible. So the only way to sort this out is clinical trials. There have been a number of pilot studies, the EFIT study in the UK and the FIRST study in Canada. The UK looking at, well, both of these actually looking at fibrinogen concentrate. The UK deciding that their protocol wasn't feasible, but the Canadians, the FIRST study, deciding that theirs was. The UK doing the cryostat pilot study and deciding that that was a more feasible study in their context. And so going on, sorry, one more pilot study, the Retic Study, and this is a bit of a problematic one to interpret from the Austrians. They published this where they randomised patients to either FFP or fibrinogen concentrate, but if you were in the FFP group, more than half of those patients crossed over to fibrinogen concentrate, and they took this as evidence of the efficacy of fibrinogen concentrate. They terminated the study early and concluded that the fibrinogen concentrate was working, which a few of us sat in the audience and scratched our head and said, I'm not so sure that's true. They did show fewer people in the fibrinogen concentrate group to start with got a massive transfusion, but there were no other differences in outcome. So I'm not entirely sure that that's convincing evidence. What will be convincing evidence is the subsequent studies from the UK and the Canadians. The UK pursuing the cryoprecipitate route. The Canadians, the details of their study, which I think actually has now been funded, but details of the study not yet been published, but pursuing fibrinogen concentrate not yet released. But they will answer this question, we hope, in the next few years. The Austrians are also pursuing this thing, the FI in tick study, only 67 patients, again terminated but not yet published, but hopefully we'll have the results of that soon. Zoe's already alluded to this trial, the Retic Study, which has finished recruiting. A trial not so much of fibrinogen concentrate, but of ROTEM-guided therapy, which should be published before the end of this year, which will be enormously helpful as well. And then there's our own study, the Feisty Study, which has been published, not been published, but been presented already by James Winnells. I'm very grateful to him for the details that I'm showing here. The pilot study, where people were randomised to a ROTEM-guided protocol that gave them either cryoprecipitate or fibrinogen concentrate, endorsed by the ANZIC CTG. Recruited ahead of schedule, a remarkable achievement by James and the team. Demonstrated that if you were randomised to fibrinogen concentrate, you had a better A10 compared to if you were randomised to cryoprecipitate. You got your fibrinogen concentrate significantly earlier than you got your cryoprecipitate, so median of 29 minutes versus 60 minutes. But no difference in any of the secondary outcomes. And unfortunately, probably just because of the play of chance in this very small study, a higher mortality in the fibrinogen concentrate group. So the question is, what will Feisty 2 look like? And that's the matter of considerable discussion at the moment. We think that the UK and the Canadian studies are going to be very important because they're delivering very early fibrinogen in one form or another. But that's a fundamentally different question to the one that we think is important in Australia and New Zealand, which is whether a ROTEM or TEG guided strategy that gives people fibrinogen in concentrate versus cryoprecipitate form is beneficial to them as a patient-centred outcome. And what's more, is economically beneficial for our healthcare system. So that's the question we need to kind of tease out, and we haven't quite worked out, or at least the Feisty investigators haven't quite worked out exactly the right study design, but no doubt they will, and that study will probably start towards the end of next year. We are doing this differently because in particular we don't want to give product to people who might not need it. In other words, we want to use a ROTEM-guided protocol rather than one that gives very early fibrinogen to everyone who comes through the door, based on the results of our pilot study, where around 50% of people who by protocol should have got early fibrinogen actually didn't need it according to their ROTEM results. So on that note, I hope I've made you think. I hope I haven't stopped you giving cryoprecipitate or fibrinogen if someone's bleeding to death in front of you. I think that is the right thing to do. But I also hope that if we come to you in 12 or 18 months' time with a trial protocol that asks you to randomise people into such a study, that you'll agree that there's equipoise to do just that. Thanks very much.
Thank you so much, Michael, and that was a really thought-provoking presentation. We've probably time for one quick question. Has anybody got some burning issues? Oh, could I just ask one quick question, because I think it does go back to what Zoe was talking about as well. We love our tools, we love our little machines, and we love numbers and stuff like that. Do you think there is enough equipoise out there that you will be able to proceed with, the proper trial to get it's going to be difficult, isn't it?
I think it is going to be difficult because you're right. People are going to buy one of these things. Yeah. They're about $50,000, and then they're going to want to use it. Yeah. But I think to those people, I would say that in no other area of medicine do we just use a test result. We always look at the patient as well. Yeah. And in the same way as if you just bought a blood gas machine and you saw that the patient had a low PaCO2, you wouldn't have a knee-jerk reaction to just turn down the ventilator. You'd think, oh, hang on, let's have a bit of a think about this. Yeah. I'd say, well, okay, so you've demonstrated a bit of coagulopathy on your ROTEM. Just have a bit of a think about that before having a knee-jerk reaction about what to do.
Michael, thank you very much for that.
Thank you.
Thank you.